You know, when an ambulance pulls up to a scene, it can look like total chaos. But I'll let you in on a little secret. Underneath all that urgency, there is a very precise 5-step process that turns that chaos into clarity. Today, we're going to walk through that exact process, using a real-world call to see how EMTs solve the medical puzzle one step at a time.
Okay, first things first. Every single call starts with a fundamental question. Is this a trauma call, caused by some outside force like a car crash? Or is it a medical call, driven by an illness from inside the body? With trauma, we're all about the mechanism of injury, or MOI, basically how the person got hurt. But with a medical call, we focus on the nature of illness, the NOI, what is going on inside. That one little decision changes our entire approach.
All right, so let's jump right in. Here's our call. We've just been dispatched for a 36-year-old male. He's got a fever, diarrhea, and he's been vomiting. Right off the bat, we know this is a classic medical call. And just based on that dispatch, our brains are already spinning, trying to build a picture of what we might find when we get there.
So, how do we make sense of it all once we arrive? We use this 5-step framework. Now, don't think of this as a rigid checklist. It's more like our roadmap. We start super broad with the scene itself, then we zoom in to look for immediate life threats. After that, we gather the patient's story, do a more detailed exam, and this is key. We never stop reassessing. Let's see how it works.
Step 1, scene size up. And let me tell you, this is absolutely non-negotiable. Before we even think about touching the patient, the first question is always, is the scene safe? For us, for our partner, for the patient. In this case, it is. We can see we have just one patient, and we've already got our gloves on, standard precautions. Only now is it safe to approach.
So as we walk into the room, our assessment has already started. We're forming what's called a general impression. This is that gut check you get from the doorway, and it really boils down to one simple but critical question. Is this person sick or not sick? The answer to that sets the whole tempo for the rest of the call.
But, and this is a big but, this is where experience really matters. You absolutely can't be lulled into a false sense of security. I mean, a patient can look totally fine one minute and be in serious trouble the next. So even if our gut says, not too sick, we have to keep a high index of suspicion. We have to be ready for the things we can't see yet. Okay, we're at the bedside now. Our patient is conscious and alert, but he's shivering under a pile of blankets. He confirms all the stuff dispatch told us. But then, his wife drops a piece of information that is a total game changer. He's diabetic, and because he's been vomiting, he hasn't been able to keep his medication down. Boom. Suddenly, what looked like a simple flu bug just got a whole lot more complicated. That brings us right into step 2, our primary assessment. This is where we go on the hunt for anything that could kill this patient in the next few minutes. We run through his ABCs, airway, it's open and clear, breathing, looks good, totally adequate, circulation, well, he's got a strong pulse, but it is a little rapid, and his skin is flushed and warm, which kind of fits with having a fever. So the bottom line from this quick check, no immediate life threats. And this leads us to our first major decision on this call. We know his ABCs are stable for now. He's definitely sick, for sure. But is he so critical that we need to just scoop him up and race to the hospital this very second? Or do we have a little time to investigate right here on scene? What do you think? The answer is no. Because that primary assessment was stable, we have the one thing we almost never have in this job, a little bit of time. This lets us flip a switch in our brains, shifting our focus from just life-saving to information gathering. We can stay put and really start to dig into the why behind all this. And that time lets us move into what I think is the most important part of a medical call, the investigation. See, without a big obvious injury to look at, the patient's story becomes our #1 clue for figuring out what's really going on. So how do we get that story without missing a crucial detail? Well, we use a handy mnemonic called SAMPLE. We ask about his signs and symptoms, any known allergies, and what medications he takes. His wife already gave us a huge hint there. Then we ask about his past medical history, his last oral intake, what he last ate or drank, and the events leading up to him calling us. Each answer is another piece of the puzzle. Now, while SAMPLE gives us the patient's background, we use another tool, OPQRST, to really zoom in on the main problem itself. We use this to interrogate the symptom. When did it start? What makes it better or worse? Can you describe the feeling? Does it move anywhere? On a scale of 1 to 10, how bad is it? And what's the timing been like? This is the kind of detail the doctors at the hospital meet.
Okay, we've got the story. Now it's time to get some hard data. We're going to get a full set of vital signs. But here's the thing. One set of vitals is just a snapshot in time. What we're really looking for is the pattern, the trend they create. So here's our first set. His breathing is fine. Pulse is a bit high at 110, which we'd expect. Blood pressure is normal. But then look at this last number. Blood glucose is 242. Whoa, that is dangerously high, and it confirms exactly what we were suspecting. His diabetes is a huge piece of this story. And this right here, this is the perfect example of why we talk about trending vitals. A single snapshot is just one piece of information. By taking multiple readings over time, we can actually see which direction this patient is headed. Is he getting better, worse, or just staying the same? The trend is always, always more important than any one number.
All right, we've got the story, we've got our initial data, we can now put it all together and make our next big decision. How are we getting to the hospital? And maybe more importantly, how fast do we really need to go?
You see, a high-priority lights and sirens transport is a big deal. We save that for patients who are truly unstable. And the criteria are pretty clear. A change in their mental status, major problems with their airway or breathing, or signs that their circulation is failing, what we call shock. Right now, our patient doesn't meet any of those criteria. So we classify him as stable, and that decision directly impacts what we do next. If he were unstable, we'd be checking his vitals every 5 minutes on the dot. But since he's stable, the standard is every 15 minutes. This lets us keep a close eye on him without being too disruptive while we head to the hospital.
And here we are in the back of the ambulance en route. And check this out. As you can see from our next two sets of vitals, we're seeing exactly what we wanted to see. His pulse is slowly starting to come down, and his other numbers are holding nice and steady. The trend is looking good. He seems to be stabilizing.
This chart just makes it super clear. Look at that pulse rate. Started at 110, then dropped to 104, and now it's at 102. It's not some massive, dramatic drop, but the direction is what matters. This is the power of trending. We can now radio the hospital and confidently tell them his condition seems to be improving.
So as we're handing off our patient to the hospital staff, the value of this whole process is just crystal clear. Think about it. We started with a pretty vague complaint, a guy with a fever, and step by step, we turned it into a clear, actionable picture for the doctors and nurses who are about to take over.
You know, one of the biggest dangers in emergency medicine is something called tunnel vision. That's when you get so focused on one obvious problem, like the fever, that you completely miss the bigger, more dangerous issue, like his out-of-control diabetes. This 5-step assessment is the antidote. It forces you to pull back and see the whole patient, every single time. From checking scene safety all the way to that final reassessment, this system is a safety net. It's what allows EMTs to bring logic and order to what can be a really stressful, chaotic situation. So after seeing it all play out, I'm curious, what part of that process do you think is the most crucial for turning that chaos into care?